Thank you. I feel a bit like a fraud here today because I see so many of our patients who have the lived experience of I always tell patients, my strategy is people get better to get away from me. It's worked very well for me for a number of decades now. The goals of nutrition with appendiceal cancer are to prevent or reverse the poor nutrition that occurs and the kinds of stories that you've heard today. Often people's symptoms are kind of benign. They start thinking they're constipated, they stop eating, their protein stores drop. To maintain or improve their weight and thus increase their stamina, to manage or decrease their symptoms, to reduce diarrhea, and most importantly, to maximize the quality of life. The kinds of problems that our patients see based on the amount of surgery that is performed by the surgical oncologists who do this, and I'll talk about each one of them individually, are delayed gastric emptying, dumping, a poor appetite. Some people develop sugar or diabetes, glucose intolerance problems, and diarrhea from 3 separate sources. It can be bacterial overgrowth, it can be lactose intolerant, which is temporary, and it can be pancreatic insufficiency. Delayed gastric emptying is something that occurs based on the type of reconstruction that the surgeon has to do, and the stomach decides it doesn't want to work for a while. The anastomoses sometimes are swollen. What you physically experience, if you are the person going through it, is feeling very full after very small amounts of food. Medically, we call that early satiety. For those kinds of patients, what we suggest is that you separate your solids and your liquids. You do them in small amounts because things will break down and then slide through that narrow anastomosis. Small servings work really well. Sticking to lower fiber foods and decreasing the amount of fat. Those are the things that sit in our stomach longer to digest and therefore slow down how quickly we digest. And so you're still full at the time of your next meal. And when I'm telling you I want you eating 6 small meals daily and you eat something that fills you up for the whole day, we lose a lot of ground. Shakes and nutrition drinks work very well in that circumstance. What is dumping? I tend to talk very practical English. The part of the small intestine that's outside the stomach likes for everything to be the same concentration. So when you have something high in sugar, which can be a plain Coke, or for some people dessert, some people a candy bar, once it reaches outside the stomach, the small intestine literally sends the message to the brain. It's very complicated medically, but what happens is the message goes to your brain, need fluid, too concentrated here. So all this fluid from the body rushes to that part of the small intestine. What you physically experience for the shift in your body is you can get lightheaded, you can get dizzy, you can get sweaty. And now the small intestine is hugely full of fluid, and it does not like that. Everything has been neutralized, but so it squeezes. Physically, what you experience is explosive diarrhea. One of the things that we find changes that is to have your sweets with your meal. Some people find that they need to lay down. There are certain foods that we just take off the menu for the first 6 weeks after surgery. And most people, this doesn't last forever. You can do this by limiting your portion sizes. Switching to diluting some of your juices works for some people. In the beginning, adding soluble fiber works long term, but in the beginning to have fiber, again, slows the digestion. So we delay that for 6 or 8 weeks. Poor appetite. Unfortunately, we do that to you. Most people after a major surgery, especially if any area of the pancreas gets touched and it gets touched by the chemotherapy, complain of a metallic taste in their mouth, and food doesn't taste the same. It's important that you continue to be eating frequently and small amounts. So I always tell people you have to eat on the clock. If it's 8 o'clock in the morning, you have to have breakfast because it's breakfast time. At this point, and I see my patients nodding their heads, at this point you won't feel hungry. So you have to eat based on the time of day to stay ahead of things. I generally suggest to people that they use their salad plate as their meal plate, because the other thing that happens, and it happens more with your family members, everybody wants you to get better. So they take your plate and they heap tons of food onto the plate. At this point, after surgery, the sight of that much food makes most people lose their appetite. So if we all use the salad plate and do a tablespoon of things at a time, you eat that, you're doing great. An hour later, you can go back and have a second portion. This is when microwaves work fabulously. High-fat, fried foods and high-fiber foods are a real problem in this circumstance because they sit in your stomach too long. Extremes of temperature in food bother lots of people. Sometimes really hot, sometimes really cold turn people off. I tell them let soups come closer to room temperature, let the cold foods sit out of the refrigerator, let your really hot foods cool off. For mothers, that doesn't tend to be a problem because by the time you serve everybody else, your food has cooled off yourself. Often people complain of taste and smell changes, and everybody's different in how this works. Many patients respond to adding spices. People that never ate Mexican or hot spices find that if they add Tabasco to things, they now can taste the food, and that works. You have to be careful that you're on something to protect your stomach because you will get heartburn later when you're using the high spices. The other thing that I have found, and these are things I've learned from patients, if you find that things taste funny in your mouth when you go to eat them, to have a bite of a piece of fresh cantaloupe or a piece of pineapple just before you eat your meal changes the acid taste in your stomach, and often you can taste the food again. If you have a metallic taste all the time, switching to plastic silverware and glass cups tends to not. There's something about our regular metal silverware that triggers the taste, and then you don't eat at all. Diarrhea. Many of our patients develop diarrhea after the surgery. Why do I have it? It can be from pancreatic insufficiency, lactose intolerance, bacterial overgrowth, either from the surgery and the antibiotics we give you then, or other reasons. And people that have other GI problems like irritable bowel syndromes, those don't disappear just because we've done another surgery. Sometimes they make it worse. So I'm just going to spend a few minutes talking about each of them. It becomes hard when you are the patient to figure out what is going on. And as we talk about them, you'll see the symptoms for many of them are the same. Your job as a patient is just to report what's going on. My job as your caretaker is to figure out which one of these it is and fix the problem. When people have lactose intolerant, people that were lactose intolerant prior to having any surgery, it doesn't generally cure it. But when we do belly surgery for, again, many complicated scientific reasons, the enzymes that we use to digest milk tend to disappear for a week to 10 days. They do come back, but people that were not lactose intolerant before have those symptoms. As a young nurse, when we were advancing, when I was working in staff, we learned this. As a very young nurse, we used to, after surgery, put people on clear liquids, and then they'd go to full liquids. And we found many, many people got sick. What they discovered was what a full liquid diet is creamed soups, milkshakes. It was the milk product, not the problem with the patient. So most surgical centers now go from clear liquids to soft solids so that we take that lactose piece out of the picture. But what you will experience after having lactose is in milk and ice cream, creamed soups. A cramping, a fullness, you feel very bloated after you eat, you're very gassy. That gas usually is not strong in odor, and then people have diarrhea. If you have pancreatic insufficiency, the pancreas has two functions. One, it makes the insulin that keeps us from being diabetic. It also makes the enzymes we use to digest our food. And often, if it has been irritated, it stops making the enzymes. And what people experience are cramping and fullness after they eat. The gas associated with this, because they don't digest any of the fat that they consume, is usually your family members will suggest, this is when I interview for this one, I generally turn to the family and say, and your family will suggest that you now leave the house, or they start lighting matches because it's a gas like you've never had before. In pancreatic insufficiency, because you're not digesting any of the fat is all in the stool and it floats on top of the water, or there'll be an orange sheen that is pretty distinctive. In those circumstances, the other thing that people often complain of is I may as well just eat in the bathroom because I eat and then I'm in the bathroom, I eat and then I'm in the bathroom. In those circumstances, we actually give you the pill that has the pancreatic enzymes that you're missing right now in it, and it solves the problem. With bacterial overgrowth, the problem is that if we've given you antibiotics for one reason or another, we have knocked down the normal bacteria or flora, as we call it medically, in your intestine, and one or two in particular seem to be resistant, and they grow like crazy, so they wreak havoc. And what they do the same thing, cause a cramping, a fullness, gas, without eating anything. Those stools tend to be distinctive in odor, and they tend to be distinctive in color. But can you see the pattern that the same thing happens? It's a matter of figuring it out. Weight, calories, and stress. This is a huge issue for patients after the magnitude of surgery that you have with a high PEC. And we start, the nutritionists that work with us start with your ideal body weight. That is altered a little bit depending on your age and your body habitus. But the way that it works when they figure that out is men get 6 pounds more than women just for being alive. They get a base of 106 pounds plus 6 pounds for every inch they are tall over 5 feet. Women get 100 pounds plus 5 pounds for every inch they are over 5 feet. And then, as nothing that we do is easy, we talk about it in pounds and then we convert all the calories to kilograms. So for those of you that are no longer in math class, 1 pound is 2.2 kilograms. Normal caloric intake for everybody sitting in this room today is 25 to 35 kcals per kilogram per day. That's how when they put you on weight loss diets, they figure out what you should weigh. When you add stressors such as surgery and cancer, and they're each their own category, you increase what my caloric needs are each day by 1 to 1.5. So if I'm someone that they figure needs 35 kcals per kilogram per day, and now I have cancer and surgery, I probably need 39. If I'm not eating, it's very easy to just slowly lose a little bit of weight just by being active. In addition to that, when you're in the hospital in a circumstance like Andy was describing, we increase just healing. You need 1.3 kilocalories per kilogram, calories per kilogram of body weight every hour just to hold where you're at. How does the food that we eat break down? Most people, you'll see on the labels of food, it gives you the protein, the carbohydrate, and the fat. How they break down for you. Protein is essential to repair the muscle and body tissue, which is why those of you that work with me, I push that protein right after surgery. I don't worry so much about the calories. We're trying to rebuild. It's 13% of our diet. The sources of protein are things like egg, milk, meat, and fish. We don't store extra amounts, and we usually need about 1 gram of protein per kilogram per day. It translates to, there are 3.5 calories in 1 gram of protein. Carbohydrates are our main source of energy. They comprise 50% of our diet. That's the kinds of things you see in sugar, bread, grains. Most people are familiar with the Atkins and South Beach diets, which control for carbohydrates. So all the stuff that you can't have on those diets are the kinds of foods that we're talking about. There are 9 calories per gram in a carbohydrate. Fat is another source of energy. It's important for us to be able to absorb our fat-soluble vitamins, which we'll talk about in a second. We get 30% of it from our diet generally. 60% of the human body is water. We need to replete that while we're healing. As a provider, there are some lab tests that we obtain when we're worried about how things are going or when we're just watching things. Albumin is the one that you see listed most of the time in the circumstance of, in total protein. In the circumstance immediately after surgery, it's not a good marker for us because what your albumin level will be today reflects what your nutrition was. The half-life, or how long it hangs around in the body, is 3 or 4 weeks old. So right after the surgery, it's not an accurate reflection. And with that big incision that you get, as the body tries to heal, all that fluid that comes out, all those tubes that Andy was talking about, bring with them is protein-rich fluid. So we lose more and more albumin. And values below 2 are not good predictors for healing. And surgeons, if your protein stores are that low, have to think seriously about if and when we can pull the trigger on doing a surgery because your healing power will be very compromised. In this period of time after surgery, when we're looking to see how nutrition is going, we get a pre-albumin because that is a reflection for me of how your eating has been in the last few days or how your protein levels have been. Vitamin A, D, E, and K are those water-soluble vitamins that you need fat, that we can't hang on to them. We have to keep taking them in. Many centers add vitamin C as an extra vitamin because it improves in healing. We don't do it so much with our high-PEC patient. Our plastic surgery colleagues put all of their patients on it. B6 is something that we often look at when people get the chemotherapies that give them the neuropathy so that they lose their feeling in their fingers or they have constant tingling and numbness. People that haven't received those chemotherapies will often come into the office and have those complaints, and we look at the B6 because if we replace it, the symptoms go away. The other thing that happens is people move their way through this illness. I find they become very astute at knowing and understanding what a lot of their blood levels are. And anemia can be a chronic problem even if you're not getting chemotherapy, even if you've just had the surgery. When you have a GI disease like this that goes on and on and on, people develop what they call an anemia of chronic disease. And their counts may be much lower than mine, but they can still cycle, as Andy's talking about. And I'm sure that he will continue to do that as he's receiving his chemotherapy because the body adjusts. The next question people ask is, what should they eat? I've already told you I push protein, chicken, fish, eggs. Anyone who's been in clinic with me knows that I'm a huge peanut butter pusher. You get more bang for your buck. Any soft cheeses, tofu, yogurt. Supercharged milk. One of the things that I send when we meet patients in the clinic before surgery at their initial discussion, even if they're not staying in our center, I have people go out and buy powdered milk. It's in the bakery aisle at the grocery store. People will call it, it's generally non-fat, it's pure protein, and you can supercharge your regular milk, but you can supercharge everything that you're eating. I suggest to people that they have scrambled eggs at breakfast because you can make them the way that you normally do. Throw a scoop of the powdered milk into them. You're getting twice as much protein, but you're not increasing how much you have to eat. You can add it to the yogurt that you're eating. Switch to making mashed potatoes because you can mash your potatoes the way you normally would with milk and butter and add a scoop of the powdered milk to it. You're doubling it. You can add powdered milk to all of the milk products that you use. You can mix it into cream soups. Doesn't work so well in chicken noodle and those kinds of soups. It's pretty obvious. You can't sneak it by anybody. All the things that they always say to us about watching the fat and butter and margarine and cheese, have all you can get your hands on during this period of time. They're good sources of extra energy. Graham crackers and peanut butters is a perfect snack for two reasons. You can take one graham cracker, put peanut butter on it, fold it in half. You're getting a nice set of fiber that you can digest that help with the diarrhea and the bowel problems. It's pure protein. It's very portable. You can put them in baggies and carry them with you every place. Anyone who's been in clinic with me knows that I'm always looking when you come in that people in this situation should be traveling with snack bags all the time. You should always have liquids with you. You should always have something to munch on. There are foods that I take off the menu for the first 6 weeks for our patients because I've been doing this a long time now, and there are just certain foods that people don't digest well. It's easy, and then if you have a bad experience with eating, you stop eating. Red meat is not your friend the first 6 weeks after surgery. It's fibrous, it sits in your stomach forever and doesn't pass through. Raw vegetables and salad, very healthy foods. They work for us in weight issues later to help us feel full, but that's exactly what they do after surgery. They sit there for hours, you're feeling full, and now you've skipped your next meal. People do better with cooked vegetables, and vegetables that would have made you gassy before your surgery. Broccoli, cauliflower are vegetables to avoid for the first 6 weeks. The vegetables that work the best: peas, carrots, green beans, any of the squashes. Cooked, they digest quite nicely. Fruits, I don't take any fruits off the menu. I do suggest if apples, pears, or nectarines are your choices, that you skin them. That all of the fiber in those vegetables, which is very good for you 6 weeks down the road, sit in your stomach and do the exact same thing as the red meat. Taste and smell often change. We've talked about that a little bit. Spices, and I have many people who never used mustard who become big mustard aficionados after surgery, so it does definitely speak to the fact that taste changes. What should you drink? Most of us need 6 to 8 cups of liquid a day. I tell people that they need to be drinking enough liquid that they should need to pee every 3 or 4 hours, and your urine should be fairly light in color. If you're only going 2 or 3 times a day or your urine is very dark yellow, you are not hydrated well enough. Normally, I'm a huge water pusher. We talked about the fact that the body is 60% water. But in this 6-week period after surgery, I always am looking to get a twofer. I tell people we need to get more bang for our buck. So I suggest that everything that goes in your mouth have calories in it. That if you only drink water, you will wash your salt out and you'll feel logy and slow and like you're thinking in slow motion. So if fruit juices feel too sweet to you or to your family member, dilute them half and half with water. Coke doesn't tend to work very well. Carbonated beverages don't tend to work very well. Ginger ale people do well with ginger, or candied ginger has a settling effect on the stomach. So if ginger ale is your choice, I tell people to let it go flat. Shakes, broths and soups, decaffeinated coffee and tea, and for those of us that are caffeine addicts and will get the headaches without, we do compromise and use caffeinated. Jell-O and popsicles, and all of the sport drinks. Supplements. This is just a picture of the different ones. I actually recommend an awful lot of Slim Fast, and when I first started doing this, patients would say to me, but that's a weight loss product. You told me you want me to gain weight. Part of the problem that I find with the supplements that are out there, they are pricey. They cost about $1 a can. I'm talking about things like Ensure and Boost and Glucerna. And most people in this immediate period after surgery can't drink the whole 8 ounces at once. They're too full. So they drink 4 ounces and put the other half back in the refrigerator. There's something about the supplements that when you take the second half out, it tastes dead. That most people find that they waste it and they can't get it down. If you have access to supplements, and some insurances cover them, and you find that they're too sweet, cut them half and half with milk. If you find that they're too strong, you can cut them half and half with ginger ale, and it makes like a black cow that many people will remember from, drugstore days. But Slim Fast is one of the products that comes in a powdered form. The vanilla powder you can mix in a blender with fruit, with anything else. The beauty of it is our Carnation Instant Breakfast comes in a tin too. The beauty of those two are you can make 4 ounces at a time, so that every time you have it, it's a fresh drink and you have a greater tendency to have yourself or your loved one finish it. There are 3 types of wellness: mind, body, and spirit. Mind involves emotional and the need for information. Body involves nutrition and exercise, and the spirit is religious and core. When you first get this diagnosis, we've heard a lot about how people get their information. One of the places you can get it is the doctor's office. The American Cancer Society is a huge resource. In our institution, we have an American Cancer Society resource room, and Mary Turvey is here with some of her information. They have computers. They can help you go online and get information. The website is here. PLWC is People Living with Cancer. It's not specific to PMP and some of the other websites we've seen earlier. NIH and NCI all have websites that if you just Google the name, it will come up and you can go in and pick out your cancer by site. There's a huge emotional toll with receiving any of these diagnoses. Some people do come to the doctor's office alone. In that case, you have to tell your spouse, you have to tell your children, young or old, you have to tell your family, you have to tell your boss, you have to tell your friends. People worry about sexuality, different things, the loss of sexuality. How can I continue to have sex with this big belly incision? Will my partner still want to be anywhere near me? They're real issues, they're things that we bring up. Dr. Makowski mentioned loss of self as you now become your cancer. Support groups can be an important key. We have a support group here at UMass that meets on the second Monday of every month from 4 to 5. And we're also very fortunate that not only do we have myself, Dr. Lambert, and another nurse practitioner, but we have a personal trainer who comes too. Many of our patients really just need to get moving, and he designs personal exercise programs for patients. It seems very simple, but when you have an incision from here to here and you're trying to get active again, it's not as easy as it sounds. Counseling is important. In our institution, we have a health psychologist who's connected to our cancer center. If you don't have one in the area that you're in, I'm sure that you can find one. And when you're looking, psychologists are very good at this. They do relaxation and other techniques, but what you want to ask when you're looking for that, if it's not associated with a cancer center, is if this person works with cancer patients. Cancer is not an easy thing for anyone to talk about, and therapists are no exclusion. There are many people who are not comfortable at doing it, and you're better off meeting someone who is interested in working with cancer patients. There are all kinds of sites for caregivers, families, and friends. There are internet sites that you can use to set up caregiving plans for people that have, like Andy and his wife, that have young children, that people can sign up to cook meals, to transport people. The internet can be a wonderful resource, and that people can coordinate in that way. Finances are a concern for everybody. Health insurance in our state isn't so much of a problem because it's mandatory to have it. The American Cancer Society has all kinds of resources. They provide rides. You can get wigs. We use, Dr. Lambert has patients that have traveled from all over the world, and many of our patients stay at Hope Lodge, which is a housing here in Worcester supported by the American Cancer Society where a patient and a caregiver can stay free of charge, and they transport them back and forth to all of their doctor's appointments. Social Security disability. I always tell people if there's any question in your mind, let's get that paperwork started early because it takes a long time. There are multiple forms. And even with a cancer diagnosis, there tends to be a rejection the first time around. FMLA and long and short-term disability are things that people often confuse. FMLA is the Family Medical Leave Act. It's a federal law that says your job must be protected 12 weeks straight or for a year. It's paperwork that the healthcare provider fills out. It has no monetary association. It just protects you while you're out of work. To get paid, you have to have a long and short-term disability plan. And in most companies, you pay for that yourself. You know, these are the questions that I ask patients when we first meet them because you will be out of work at least 6 weeks. Generally, it's longer. And doing all of that paperwork takes a while. It takes a while to get through your own employer's human resource department. And often I continue to be surprised at how many people don't know. Some companies, and that's what you need to ask your human resource person, many companies pay for a long-term disability for their employees, but that doesn't kick in for 6 months. And if you want short-term disability, you have to sign up for it yourself. You'd know you're getting it because it will be a deduction in your paycheck. It isn't something that just happens. The kinds of physical issues that people worry about, Andy also mentioned. One of the first questions people ask when we're doing all this belly surgery is, am I going to wake up with a bag? In our institution, when we know or can predict that, we have them meet with our woundostomy and skin nurses beforehand to have them mark them and give them bags to begin to at least become somewhat familiar. We've already talked about sexuality, fertility, and parenthood. We have a smoking cessation program here. I'm pretty upfront with people. It is in their best interest to quit smoking, but I also recognize that most people who are smoking use it as a stress reliever, and we have now just launched them into the most stressful period of their lives and say, oh, by the way, could you just stop? That we do have a mechanism that we use for that. Genetic counseling is something that people ask a lot about. We've already heard the information today that this is not something that's hereditary that people pass on, but I always bring it up. Help at home after the surgery. Every institution, no matter where you receive your care, has case management. They're generally nurses, a cohort of nurses and social workers who help to figure out if you can go home, what you need to go home, if you need visiting nurses, if you need a homemaker. There's a difference between a homemaker and a home health aide. A homemaker can do household chores. They can do your cooking, your cleaning, your shopping. A home health aide can only do personal chores, help you bathe, help you dress, help you shower. People don't often understand that. And they'll say, oh, no, I don't need one, I don't need the other. Someone who lives alone and now cannot drive and has to be homebound has no mechanism to get groceries into the house. That would be someone who would benefit from a homemaker. This is a website that's for breast cancer patients. There are a group of breast cancer survivors in our area who clean houses free for breast cancer patients. I actually put it up on in my talks whenever I can because I think it's the impetus for us to think about what we can do in our other disease sites. Spirit and core is part of wellness. Meditation can be very important. Centers for Mindfulness, and John Kabat-Zinn, who's world-renowned for that, happens to be here at UMass. A lot of our patients avail themselves of that. Visitation by family, friends, and ministers. And often patients that we have use Hope Lodge and travel a great distance, and it can be very hard for them. The only people they see while they're here is whichever family member is staying at Hope Lodge, Dr. Lambert, our team, and the staff on the 7th floor, which is why I think some of those bonds become so intense. I actually became a Reiki master many years ago when patients began to request it and couldn't receive the treatment here, so that we can, all of the alternative therapies had gone out of vogue because there was no reimbursement for them. I find that they're coming back. But massage therapy, music therapy, yoga, Tai Chi, and Pilates are key in many people's recovery. Alternative treatments, acupuncture and reflexology, many people benefit from those kinds of things. Exercise is very important. You need 30 minutes of purposeful exercise every day. It doesn't have to be all at once. It can be broken into 3 or 4, 5 or 10-minute sessions. It helps to relieve stress, it improves your stamina, and actually recent studies that have come out in colon cancer, now that we have so many survivors, most of the data that we have is around breast cancer and prostate cancer because they're the largest group of people. There are now more and more colon cancer survivors, and there are 2 studies that have just come out that have shown that the time to recurrence and the response to treatment were in the 60% were significantly improved in people who exercised 30 minutes at least 3 times a week than those who did not. And it doesn't have to be at the gym, it doesn't have to be cycling, it doesn't have to be running, it can be walking. Depression is a key. We've talked about that. People's religious affiliations, we have denominational and non-denominational ministers. Don't not think about talking to those kinds of people. We've talked about the alternative therapies. Wellness, fatigue, and the balance. You need, this is the story that I tell people after the surgery. When you first go home after the surgery, it's like bringing a new baby home. You get up in the morning and you either bathe or you eat, and then you don't have the energy to do the other one. You have to rest before you can do. So you can guess which one I suggest that people do. I prefer that you get up and have something to eat, take your nap, and then wash up. And then people do okay. And they kind of poke around a little bit. And then at 4 o'clock in the afternoon, the body has an internal clock. It's called a circadian rhythm. And unless you work nights, it happens at 4 a.m. For those of us who work daytime, we hit the wall at 4 p.m. For a patient that has just had a major surgery, they need to actually lay down. They will go out cold, sound asleep for an hour and a half. It doesn't have to be in bed. It can be on the couch in the recliner. Then people generally get up and they poke around a little bit, and then they go back to bed. Generally at this point about an hour and a half earlier than they normally would. Typically it's just like bringing a new baby home. The first nap that disappears is the morning nap. And then in about 6 weeks, people are just sitting down. And I usually, in the clinic, I'll say to people, and that's when they start hitting the clicker, and then they discover Oprah. But I realize that after today, I'm at work during those hours. I don't know what's on, and I don't know what people will be watching at 4 p.m. In our institution, it is standard practice that we involve physical therapy and occupational therapy within the first 48 hours after surgery to have them evaluate whether you can go home. In Worcester, we are the 3-decker capital of the world, so many of our patients potentially live on the 3rd floor with no elevator access, and after this surgery, going up and down 3 flights of stairs more than once a day is not something that people can do. I have a rehab background and learned many years ago that the key to getting people into rehab, to get someone to an acute rehab, is about 2.5 hours of therapy a day, and people get back on their feet more, but the key is to get them in there at the right time. Household distances is considered 150 feet. So we need to get you referred before you're there. If you're walking 150 feet in the hospital, then you're too good to go to an acute rehab, and you end up going to a skilled facility, which you only get about an hour and a half of therapy a day. You'll see I have pictures here. You know, it doesn't have to be fancy. We in our institution have printed some TheraBands that say surgical oncology for patients, but Joe, our personal trainer, has shown many of our patients how to use soup cans, how to use their counter and just squat, that you don't have to have, I learned something, instead of using a treadmill, having a tire, that you just walk on a tire. I've tried it. It's quite amazing. It costs nothing. When you get back, even people who are athletes, when they first start back, I say to them, my runners, I say you can't run more than a quarter of a mile a day. They're shocked that they're pooped. Their stamina comes back quickly, but it's real. If you're doing lifting kinds of exercises, I say no more than 5 reps today, and then each time you start, it's amazing how quickly it comes, but it's hard to be patient. At that point in time, most patients have had enough of this already, and they're ready to move on, and it becomes very hard to be patient with their progress. I use this slide from the American Cancer Society a lot. I do talks on survivorship as well, and the keys are managing our diet, our weight, and our physical activity to prevent this cancer from coming back or another cancer from coming forward. Now I'm going to turn it over to Kate.
Hi, everyone. So I can't tell you how ironic it is that I'm talking about exercising because I never exercised before I was diagnosed with cancer, and it's kind of embarrassing that it took a cancer diagnosis to get me to the gym and walking my poor dog, whose name is Fenway, by the way. You guys would appreciate. My husband's from Boston. So as Dr. Lambert said, I had my surgery in 2009 at MD Anderson. And I kind of looked at exercise as a three-pronged approach: what to do before the surgery, what to do immediately after the surgery, and then what to do long-term to try to get me to exercise more. So pre-surgery, I kind of felt like in order to get my heart ready and my lungs ready for this major surgery, I needed to start walking, run if I could, go to the gym. And I did that for about a week, and then I started to get bored. And I realized I need to do something that's a lot more creative than just going to the gym. So I instructed my husband to help, and because we live in San Francisco, we've got these incredible hills and incredible stairs, and pretty good weather to get out and exercise in the outdoors. And that's what I did. I got a book on how to, where all the beautiful stairs were in San Francisco, and where all the great walks were for dogs off leash. And I just tried to make it creative and try to make it fun. And we both benefited from that as well, actually. The other thing I wanted to do, because I knew I was going to be lying in bed for hours and hours recovering, was to work on strengthening my muscles. I knew they would be atrophying, and I knew if I wasn't strong, then everything else around that would break down. So I worked on strengthening my back, essentially, strengthening my legs, and strengthening my core. All the things that I knew would kind of break down after lying in bed for so long, and it helped. Some people going into surgery think, okay, I should lose some weight. They're going to be cutting me open. They're going to see all this fat around all my organs. And it's true, you saw on the slides all that's there. And I kind of had a different situation where I felt like I needed to gain weight before the surgery because I was told I was going to lose a lot of weight. And I dreaded the thought of looking at myself in the mirror and actually looking sick. So I tried to put on as many calories as I can. Peanut butter was a really big help and a lot of fun. And it actually worked. My surgeon came out of the surgery and said it was actually such a blessing to be able to work on somebody without a whole lot of fat. So it's not just the mirror that can tell you that you should maintain good weight. When your surgeon says it's nice to open up somebody and not have to get around all of that, it's proof right there. Try to maintain a healthy weight, whatever that weight is. I was told that right after the surgery, I think the next day I was going to walk. And I thought, oh great, this surgery is not going to be much of a hard time then if I'm going to be walking the day after. Woke up, realized they want me to walk in how many hours? And there was a picture of me. I've got my big tower of all the tubes and everything, and 3 large nurses standing around me in case I were to fall, and I'm hunched over and I'm walking like this, and I couldn't believe it. I could not believe that soon after surgery I was on my feet. And it took a lot of prep work before the surgery to get me to be in that mental space. Okay, I need to do this, I need to get ready for it, and to have the support system around me to say I can do it. And it started with 1 walk around the nurses' station. Next day it was 2 walks around the nurses' station. I kind of just hit these landmarks, and the next thing I know, the nursing station was almost like a bar. I would just sort of saddle up to the bar and talk to all the nurses, and you feel your body getting better just by standing, just by walking. And it's all, as someone mentioned before, it's like all the fluids just moving, and the body isn't made to just sit all day or lie down all day. And I really felt like moving and walking around was so key to feeling better quickly. Also early stretching. There was a lady who had my same surgery, and she said that she couldn't lift her arm for weeks after the surgery to brush her hair, and I thought, oh no, I can't let that happen to me. I can't not brush my hair for 6 weeks. So I every time I would adjust my pillow in the bed, I thought, oh, this really hurts to move my arms. I shouldn't move my arms. And then I remember that lady telling me that, and I thought, you know, I'm going to push through the pain. I'm going to push through the pain and adjust my own pillow. And sure enough, by the, 10 days later, I could lift my arms straight up without any pain, without any problem. I wish I had done the same for standing up straight, because it took me about 3 or 4 months to totally stand up straight. So it just goes to show that moving around, pushing your limits, pushing your boundaries, at the end of the day, really, really can help. And also laughing, oddly enough, you use so many abdominal muscles when you laugh and when you talk, and all of my friends and family would come into my room and say, and try to make jokes and try to make me laugh, and I'd laugh like this and go, oh, it hurts to laugh, it hurts to laugh. But the more I would laugh, the easier it got. And still to this day, sometimes when I laugh and when I sneeze, I still feel a little bit of pain, and it's just a reminder, keep laughing. Keep using those muscles, keep stretching. So when I got home, and it was a lot harder to walk around the block because the blocks are like this in San Francisco, I would walk around the house. We have stairs in our house. I would do the stairs. It was harder to walk my dog because she pulls on the leash so much. She's a lab. I had to find other motivations to try to get me to exercise. And that's really the key, is find what works for you. If going to the gym doesn't work, don't go to the gym. Do something else. And I was lucky enough, around the corner from my house was a Pilates studio. And Pilates was actually first started for rehabilitating men and women who came back from war. And usually with, missing this and missing that. And it's basically a pulley system. And you can target specific muscles. And it was really hard for me to do a lot of exercising because so much exercising is involved with the core. And so with Pilates, I was able to focus on the other muscles, focus on all the stabilizing muscles, and then work on the core. And not just the whole core in terms of doing crunches, but I was stronger in my lower abdomen for some reason. You guys would probably know better than I. And so I was able to focus on the lower abdomen first and then kind of work the way up. And that helped me tremendously after surgery because it was so hard just to get around because all of your muscles atrophy. And just rolling over in bed or cooking yourself a meal, all of those things became so hard. And so being able to target all these specific muscles and really work on strengthening helped immensely. And the good thing about Pilates for a non-working out person was that you have to make an appointment. It's not like a gym where you just show up. So for me, having that appointment, knowing that people were relying on me to be there, got me there. Otherwise, I wouldn't. I just wouldn't have done it. So Pilates really helped. And another thing that I found too was a new thing that I'm into for cardio, because I found that it's taken me, I'm 2 years out and I still don't feel like my heart is back to where it used to be, my strength, my stamina. And so now I've been doing squash, which is similar to racquetball. And squash has been a lot of fun, again, because I have somebody there to depend on me to be there. And it works all the muscles and it works the cardio. I mean, Andy, you probably know, that the heart muscle is the strongest one you've got, and everything else is dependent on that if you want to work out and keep it going. So for me, I kind of had to be creative to find something that worked for me long term in terms of exercising. And I have the motivation now, the motivation to keep going, keep exercising, and unfortunately it took PMP to get me there, but I'm there. So thank you all very much.